Hi guys, my name is Anton Meiring and I'm going to provide you with a quick overview of one of the most common microvascular complications of diabetes mellitus, diabetic nephropathy or diabetic kidney disease. Let's delve in. Diabetes is a metabolic disease where there is inadequate control in blood glucose homeostasis, the way your body responds and controls blood glucose levels. There are many subtypes, and the most common are type 1 and type 2 diabetes. Diabetes causes an inadequate rise in blood glucose levels because of inadequate insulin secretion or inadequate insulin action. This leads to a large variety of complications if not adequately treated by a medical professional. Looking at the diagnostic criteria for diabetes, one will be diagnosed with diabetes if your fasting blood sugar level is more than 7, if your 2-hour post-oral glucose tolerance test is more than 11.1, if your HbA1c is above 6.5%, or if a random blood glucose level is above 11.1 and you have symptoms such as polydipsia, polyphagia, polyuria, and weight loss. This brings us to the next question. What is diabetic nephropathy? Diabetic nephropathy is a microvascular disorder having a similar pathophysiology as retinopathy and the neuropathies. In the glomeruli, early changes include podocyte dysfunction. This is the cells that covers the basement membrane, leading to basement membrane dysfunction. Early changes in diabetic nephropathy is thickening of this basement membrane. Mesangial cells also undergo hypertrophy and produce more matrix proteins, ultimately resulting in glomerulosclerosis. T cells and macrophages are recruited to the glomeruli that also mediates diabetic nephropathy. The renal tubule undergoes hypertrophy because of the glucose hyperfiltration and the upregulation of the glucose transport. This causes a decreased sodium delivery to the macula densa, activating tubular glomeruli feedback and increased filtration. Over time, tuberointerstitial fibrosis sets in, altering the way the nephron responds to the filtered proteins and increasing urine albumin loss. So the next question is, what is your risk of developing diabetic nephropathy? Approximately 30 to 40% of diabetic patients will develop diabetic nephropathy at some point during their lives, with another 15% of them going on to develop end-stage kidney disease. So a variety of factors plays a role and contributes to this condition, including the duration of diabetes, uncontrolled blood glucose, poor glycemic control, smoking, obesity, dyslipidemia, limited access to nephrologist and specialist care, ethnicity, where there's a higher prevalence in British, Afro-Caribbean, and South Asian patients, and also the use of nephrotoxic drugs. So how is diabetic nephropathy diagnosed? A very important thing here is patient screening. Patients diagnosed with type 1 diabetes should be screened for diabetic nephropathy from 5 years after diagnosis and yearly thereafter, where patients diagnosed with type 2 diabetes should be screened at diagnosis and then on an annual basis. Diabetic nephropathy is usually picked up when on a spot urine sample where there's a protein secretion between 30 to 300 milligrams per gram. Worsening of this level of proteinuria is the hallmark feature of progressive diabetic nephropathy and possible renal function impairment. The overall renal function should be calculated by determining the eGFR for each patient, and these patients should be referred to a nephrologist if the GFR drops down to below 30. So should you be diagnosed with diabetic nephropathy, the question is, how will you prevent disease progression? So firstly, intense glycemic control is of paramount importance, one would aim for an HbA1c of less than 7%. Adequate blood pressure control is also important, where one would aim for a blood pressure target of 130/80, or in the setting of proteinuria more than 1 gram in 24 hours, one would aim for a blood pressure of 125/75. Renin-angiotensin system blockade with an ACE inhibitor or an ARB, especially in type 2 diabetes mellitus, diminishes the risk for the development of nephropathy and concurrent CV. Dietary considerations will include a decrease in the protein load, because a decreased dietary protein load is proven to prevent the development of end-stage kidney disease. The heart protection study as well as the CARD study showed that when one treats a dyslipidemia with a statin, this also preserves renal function. It's also advised to use aspirin for thrombosis prophylaxis. And then anemia. Renal failure is often associated with anemia, and this anemia is also an independent risk factor for the development of kidney disease. So these patients should be treated by the clinician to a target HB between 12 and 13 milligram per deciliter. So, what is end-stage kidney disease? Under circumstances, patients with diabetic nephropathy may progress to end-stage kidney disease. End-stage kidney disease is defined as having a GFR of less than 15. This advanced stage of disease is associated with several serious complications, including hyperkalemia, a high anion gap metabolic acidosis, disruption in fluid and sodium balance, leading to peripheral and pulmonary edema and hypertension, anemia, secondary to reduced erythropoietin production in the kidneys, and also mineral and bone disorders. So how is end-stage kidney disease managed? Well, the management focuses on addressing the underlying causes and mitigating complications. Firstly, one would try to treat the underlying disease process, often by correcting glucose control and blood pressure control. Optimizing the glycemic and blood pressure control to slow further kidney damage. Correcting metabolic acidosis, often with the use of oral bicarbonate. Manage the fluid overload with loop diuretics. Treating the anemia with iron supplements and erythropoietin stimulating agents. Control phosphate levels with phosphate binders. Implement dietary modifications such as a low salt and low protein diet. And then lastly but not least, supplementing vitamin D and calcium. At some point in end-stage kidney disease, one would consider renal replacement therapy. The indications for renal replacement therapy include severe acidosis, the development of encephalopathy, malnutrition, severe gastrointestinal symptoms, persistent hyperkalemia, pericarditis, volume overload, and an absolute GFR between 5 and 9. Please remember that metformin should not be initiated in patients with a GFR less than 45. In your patients on metformin, you should monitor the renal function, and if the GFR drops down to between 45 and 60, the dose of the metformin should be halved. The reason for this is the risk of developing lactic acidosis. Other agents such as GLP-1 receptor antagonists, as well as SGLT2 inhibitors, might play a role in kidney disease beyond that of just glucose control. SGLT2 inhibitors reduce the interglomerular pressure by inhibiting glucose and sodium reabsorption. They may also enhance renal energy availability by increasing the availability of ketone bodies for renal metabolism. As the GFR declines, insulin clearance may be reduced. So please remember that your patients on insulin might have a decreased insulin requirement as the disease progresses. Future directions in diabetic kidney disease. Recent advances in molecular research in kidney pathology hold significant promise for the treatment of diabetic kidney disease. Initiatives such as the Kidney Precision Medicine Project, Trident, and Beat DKD are pioneering efforts to develop precision medication approaches to diabetic kidney disease. Well, this brings us to the end of our discussion on diabetic kidney disease. I hope that you found this short and concise discussion informative and that you have a better understanding of the complexities in the management of diabetes and related kidney disease.